Good day, dearest great surgeon. Miss you all a lot. Let's continue our beloved orthopedic chapter and let's stress that it's one of the pillar chapters for MRCS in your exam. So don't be shocked when you find your exam is about trauma, orthopedics, preoperative, postoperative, and anatomy. Because orthopedics is already overlapping with every chapter in MRCS, even the pediatrics, preoperative, postoperative, anatomy, and the orthopedics itself, and the pediatrics. So let's go for it and crack this chapter together. Together we can, with the grace of God. A very famous scenario in the exam is about the crush injury. The combination of crush injury, limb swelling, and inability to move digits raise suspicion to compartmental syndrome that will require eventually fasciotomy if you are willing to save this limb for the patient. And by the way, paralysis is very late sign, and loss of the pulse is a very unreliable late sign. Don't wait to lose pulsation. So compartment syndrome is a particular complication that might occur following fracture or following ischemia, like pre-perfusion injury in vascular patient, characterized by raised pressure within a closed anatomical space. This anatomic space is the muscle within contained its fascia. For example, that's why we do fasciotomy to relieve the compartmental syndrome. The raised pressure within the compartment will eventually compromise tissue perfusion, resulting in necrosis. The two main fractures that carry the highest complication include the supracondylar fracture and the tibial shaft injuries. The symptoms and signs are pain, especially on movement, which will be not logic and not going with the current situation. So it's unmatchable pain, not going with the whole current situation. And paresthesia as well as pallor may be present. Arterial pulsation may still be felt, so don't wait until loss of pulsation. And the necrosis occur as a result of microvascular compromisation. And lastly, the paralysis of the muscle group may occur. So it's PPP, pain, paralysis, paresthesia, pallor, and arterial pulsation might be still present or absent. Don't wait for its absence and paralysis. To diagnose the compartment syndrome, it's made by manometry by measuring the intra-compartment pressure measurement, and if the pressure exceeding 20 millimeter mercury, this is abnormal, and more than 40 millimeter mercury, this is diagnosed, and the treatment will be essentially extensive fasciotomy. Go break all the fascia of the compartment and let the muscle go out and relieve all those tissue. This is essentially by fasciotomy. In the lower limb, the deep muscle may inadequately decompress by inexperienced operator when a smaller incision are performed. So do extensive aggressive fasciotomy. And take care, myoglobinuria might occur following fasciotomy and result in renal failure. That's why we fear the compartmental syndrome. It's not all about the limb only, but might cause renal failure or even multi-organ failure from myoglobinuria, and it's a common question in the exam. So these patients require aggressive IV fluid replacement to decrease the reperfusion injury and the myoglobinuria that might occur and cause renal failure. That's why assessing the patient with ABC and monitoring the vital signs is essential in every polytrauma patient. Hope this made it clear. And the urine output is very essential to know is this patient having a renal shutdown or not, either due to compartmental syndrome or other cause causing multi-organ failure. Take care. Where muscle groups are frankly necrotic, at fasciotomy they should be debrided and amputation may have to be considered. Death of the muscle group may occur within 4 to 6 hours, and this is a very famous question in the exam telling you a crush injury of a patient who have been crushed for more than 6 hours, for 7 hours. This is an indication for amputation for fear of the reperfusion injury and the necrotic materials that pass into the blood and cause the patient to die from the reperfusion injury and myoglobinuria, as well from muscle necrosis. So you are going to save the limb before necrosis by fasciotomy, and if it's dead, save the patient by amputation. So the indication for amputation are dead, deadly, and useless limb. As a doctor and physician, whatever your specialty is, never underestimate your patient complaint. And as well, never overwhelm. Take care. The orthopedic pediatric will teach you this lesson very well because many mothers, no matter how much they love their children, but they have common that they underestimate their boys and children complain. A very famous orthopedic scenario is about an 8-year-old patient. He is presenting with symptoms of right knee pain. Oh mommy, I have a knee pain. And tells her this complaint for 3 months, several hours a day. And all she said that, oh boy, you are such a naughty boy. You just hit your knee and want me to pay all my money on the doctors and flee. And believe me, he is not naughty boy. He is the most polite of them all because he doesn't have the luxury to play with his fellow children because he is in pain, in severe pain. He doesn't play with his children at his age because he is in pain. Such poor child at age of 8 complaining of his knee for 3 months of age with antalgic gait and apparently leg shortening. This is your key in your exam, and this is the typical presentation of Burns disease. So what is Burns disease? Take care. There are many causes for irritable hip at the age of 10 to 14-year age group, and many of these may cause both hip pain or knee pain. And the transient synovitis of the hip is the commonest disorder, but doesn't typically last for 3 months. Even osteosarcoma wouldn't usually present with apparent lip shortening unless pathological fracture had occurred with the osteosarcoma. And by the way, the scaphy or the slipped upper femoral epiphysis can cause a similar presentation, although it's typically present later with different patient characteristics. And the key with the slipped femoral epiphysis will be that the patient will be obese. This is your key for slipped upper femoral epiphysis. While in Burns disease, we have said that it's at earlier age, at age of 8 for 3 months with antalgic gait and apparent leg shortening, and he won't mention that he is obese because obese will be your key in the exam with the scaphy. So take care. What is Burns disease? It's an idiopathic avascular necrosis of the femoral epiphysis of the femoral head. It causes impaired blood supply to the femoral head, causing bone infarction, and new vessels develop and ossification occurs. The bone either heals by itself or subchondral fracture occur. So this is the make it worse for Burns disease. Dearest great surgeons, take care that Burns disease has a clinical feature. The male has 4 times incidence than female. So in the exam, he will tell you it's all about boy. The age is between 2 and 12 years old, and believe me, he will get it an age before 10 years old to make it easy for you. He will be limping with hip pain and bilateral in 20%. The younger the age of onset, the better the prognosis, by the way. So never underestimate your patient complaint like the mother said for the patient, he is a naughty boy. The diagnosis is by plain X-ray, technetium bone scan, or magnetic resonance imaging, the MRI. If the normal X-ray of the symptom persists, so go for MRI. MRI is more sensitive than plain X-ray for the Burns disease. The management of the bursitis disease is to keep the femoral head within the acetabulum. It can be done and achieved with cast and braces. If less than 6 years old, just do observation. If older than 6 years, go for surgical management with moderate results and operate on severe deformities only. The prognosis in most cases will resolve with conservative management, and the early diagnosis improves the outcomes by following up with a pediatric surgeon of orthopedics. Let's be familiar now with the exam scenario for slipped upper femoral epiphysis SCFE. So, an obese 12-year-old boy referred with pain in the left knee and hip. On examination, he has an antalgic gait, limitation in internal rotation. His knee, normal range. Passive active movement are normal range. What is the scenario? Is this is a birth or this is a slipped upper femoral epiphysis? It is the same age. We said from 2 to 10 or almost to 12. Take care. Did you notice the beginning of the scenario? It was obese. Was your criteria for the patient. Slipped upper femoral epiphysis is commonest in obese adolescent male. The X-ray will show displacement of the femoral epiphysis inferolaterally, but in the exam he won't tell you this X-ray finding. He might ask you about the X-ray finding, by the way. And the treatment is usually with rest and non-weight bearing crutches. So beware of attributing gait disorder to benign processes in young children without careful clinical radiological assessment. So again, take care. The slipped upper femoral epiphysis, typically seen in obese male adolescent, pain is often referred to the knee and limitation of internal rotation, while the bursitis disease will be a hip pain, might be referred to the knee, usually occurring between 5 and 12, but he is not obese and he is male, and bilateral disease in 20% of the patient. And take care that this patient will be younger than 12-year-old. Okay, but the slipped upper femoral epiphysis will be in adolescence at age of 12. This is the cutoff in your exam. And the slipped upper femoral epiphysis in the X-ray will show femoral head displacement and falling inferiolaterally like a melting ice cream. So now we remember the ice cream with the VMA of the pheochromocytoma as well as the slipped upper femoral epiphysis X-ray. So take care. While the X-ray finding in the bursitis disease is not the earliest sign, it's common to be early in the MRIs and the X-ray in bursitis disease, and the X-ray finding will show a flattened femoral head eventually. In untreated cases, the femoral head will fragment. As we brought up the orthopedics chapter and the orthopedic of pediatric, let's talk about the developmental dysplasia of the hip. Take care. It's usually diagnosed in infancy by screening test. It may be bilateral when disease is unilateral. There may be leg length inequality. As the disease progresses, child may limp, and then early onset of arthritis, more common in extended breech babies. The radiological finding, initially no obvious change on plain film, and ultrasound will give the best resolution until 3 months of age. So, what is first to be done if you are suspecting a developmental dysplasia of the hip? Go for ultrasound. It will be finding giving you best resolution until 3 months of age, and it's expected at the infancy. So on plain films, Shenton line should form a more smooth arc, and it will be managed by splints and hardening of traction. In later years, osteotomy and hip realignment procedure might be needed. In arthritis, a joint replacement may be needed. However, this is the best deferred if possible, and it's almost certainly require revision. So, to make it simple, let's agree together. So we have three main hip problems in pediatric orthopedics. Developmental dysplasia of the hip, and the cut-off age is infancy. We are talking about infant. And the birth disease, we are talking about below 12 years old, and there will be no x-ray finding mentioned, and there will be no obese boy. So this is your key. Birth disease, referred pain to the knee, but not obese. If he became obese, he will tell you this patient above 10 years old, and this will be slipped upper femoral epiphysis and will appear in x-ray earlier, showing a femoral head displays falling like ice cream is melting. And again, never underestimate your patient complaint. Even if he was a child at age of 2 years old, he might be a birth disease. Be a good doctor and a good parent as well. Be safe. But don't confuse yourself with the hip pain and the gait abnormalities, especially if the patient was complaining already from a recent viral illness and you find that his TLC or white blood count about 11, which is within high normal, and the ESR is high about 30. So think of a viral illness which is associated with transient synovitis. This is not septic arthritis, because septic arthritis had another whole criteria. For septic arthritis, the white blood cell count must be above 12 and the ESR count must be above 40. So take care from the numbers and take care from the history if we are talking about a recent viral illnesses. Take care. A great mnemonic for the septic arthritis to differentiate it from the tenosynovitis or the transient synovitis is the septic arthritis wife. He's a good man, he loves his wife, where white blood cell about above 12, ESR above 30, fever above 38.5, and inability to weight pair. This is your key. This is the wife. YBC, inability to weight pair, fever and ESR. Wife. YBC, inability to weight pair, fever and ESR. Stress fracture. Can one get a fracture from just stress? Yes, it's marching stress fracture. Take care. A short history of pain together with a clinical examination and radiological sign affecting the second metatarsal favor a stress fracture. Don't confuse it with the Morton neuroma. There is no fracture in the Morton neuroma. But in stress fracture, we have a history of pain and radiological sign affecting the second metatarsal, favoring a stress fracture. The fact that the callus is present suggests that this immobilization is unlikely to be beneficial. And the Frimberg disease and anterior metatarsalalgia affecting the head of the second metatarsal is typically occur in the pubertal growth. So take care. The initial injury was thought to be a stress microfracture at the growth plate. The key feature in the history which distinguish the injury as being stress fracture is the radiology. In Fimberg disease, the X-ray change include joint space widening, formation of bony spurs and sclerosis, and the flattening of the metatarsal head. All of those findings, nothing appeared in our scenario, and if they appear, so it's Frimberg disease. If they not appear, think of stress fracture. While in Morton neuroma, there will be no radiological sign. So take care, because stress fracture is very common and be aware of it. A repetitive activity and loading of normal bone may result in a small hairline fracture. While these may be painful, they are seldom displaced. So surrounding soft tissue injury is unusual, by the way, from this hairline fracture, but they may present late following the injury, in which case the callus formation may be identified in the radiograph. Such a case may not require formal immobilization. The injuries associated with severe pain and presenting at an earlier stage, that they may benefit from the immobilization on the site of the injury. but late there is no need for immobilization. Hope this made it clear regarding the stress fracture compared to the motor neuroma as well as the Frimberg disease. So again, what is the Frimberg disease finding? There will be X-ray changing include joint space widening, formation of bony spurs, and sclerosing flattening of the metatarsal head, and typically occur with growth spur. The Frimberg disease is anterior metatarsalgia, affecting the head of the second metatarsal. So, what is now the Morton neuroma to differentiate it from the stress fracture and the Frimberg disease? So, Morton neuroma or Morton metatarsalgia is a very painful benign condition that affects the ball of the foot and most commonly the area between the third and fourth toe. But take care, it might occur as well in the second toe. Morton neuroma is involving the thickening of the tissue around one of the nerves leading to your toes. And this can cause a sharp burning pain in the ball of your foot, but there will be a sting burn, feel numb as well, but there is no fracture. This has to be your line to differentiate it between the fimbring metatarsalgia and the stress fracture. Take care, Morton neuroma, benign but painful, as well as its intermetatarsalgia neuroma because it's located at the pole of the foot between your metatarsal and happens when there is a thickening of this nerve. By the way, the high heels can be leading cause for Morton neuroma because many people experience relief by switching to a lower heel shoes with wider toe boxes. So sometimes corticosteroid injection or even surgery might be necessary, but try at least to not use the high heel. Be a high in your style, not in your shoes. Isn't medicine is amazing, full of wisdom? Keep it in mind and get inspired from the creation of the creator. Normal boys would look at street at any girl and can see a tall lady with ice cream wearing high heels and has a big eyes. But as a doctor, you have a different vision for this whole scene. What do you think of this tall lady with ice cream wearing high heels has big eyes? Yes, great. You get it well. You are thinking about Marfan syndrome, might be a VMA having phaeochromcytoma. She is wearing high heels that she has Morton neuroma and as well big eyes might denote that she is thyrotoxic. So it's Marfan, phaeochromcytoma, Morton neuroma, thyrotoxic. Would you like this girl? No, keep her alone. Don't mess with her. You will be missed your whole life because you didn't study medicine. So study medicine so you can choose your pride and the lady you walk with. So tall lady, Marfan syndrome, phaeochromcytoma with the ice cream, wearing high heels, it's Morton neuroma, has big eyes, that's cytotoxicosis. Get away and flee and save your life. So the only man that can marry a Marfanoid with a phaeochromcytoma and thyrotoxicosis is the men two criteria because he already has medullary carcinoma and phaeochromcytoma. Let them mess with their life together. Ha ha ha. Let's be serious for a while and study together our diseases of the vertebral column because it's a pillar in the exam as well as the orthopedics. And it's overlapping with the orthopedics, but it's not separate chapter, but it might come in the exam. A very famous young athletic female just completed her high jump and suddenly developed a severe back pain, was affecting both her legs with weakness. On examination, she has a prominent sacrum and her lower back is painful. This is spondylolysis. So take care. Young athletic female are the group most frequently affected by spondylolysis, who have a background of spondylitis, and the spondylolysis is a risk factor for spondylolysis. Its condition is most likely in female with athletic background who presents with sudden pain after her high acrobatic jump. So literally, she will have her vertebra become slipped, spondylolysis. So let's be clear regarding two definitions here: spondylolysis and spondylolysis. Spondylolysis is a condition characterized by a congenital or acquired deficiency of pars interarticularis of the neural arch of particular vertebral body, usually L4 and L5. This is common record, by the way, and may be asymptomatic and affect up to 5% only of the population. Spondylolysis is the commonest cause of spondylolisthesis in children. So, what is the spondylolisthesis? Spondylolisthesis occurs when one vertebra is displaced relative to its immediate inferior vertebral body. Its vertebral body slippage. It may occur as a result of stress fracture or spondylolisthesis. So spondylolysis can occur due to spondylolysis, which is acquired deficiency of pars interarticularis of the neural arch, or might be as a result of a stress fracture for the vertebra itself. So spondylolysis with the TH occur with the displacement of the vertebral body. Take care. Traumatic cases of spondylolysis may show the classic Scotty dog appearance on a plain film. And by the way, the treatment of spondylolisthesis depends upon the extent of the deformity and associated with neurological symptom. In minor cases may be actively monitored and individualized, and individuals with radicular symptoms or signs will usually require spinal decompression and stabilization, while spondylolysis, the asymptomatic cases, doesn't require treatment at all. So spondylolysis and spondylolisthesis with our athletic patient, young female. Remember the spondylolysis affecting L4, L5. Regarding the congenital disorders, we have a very famous question in the exam overlapping between the pediatrics and vertebra and orthopedics and even skin, because it might appear as a skin manifestation. Without knowing it, you can miss it. So if you know it, you can deal with it. The spina bifida. It's a non-fusion of the vertebral arch during embryological development. It has three categories: myelomeningocele, spina bifida occulta, and meningocele. Spina bifida occulta means it's hidden. So take care. The spina bifida occulta is a common condition that may affect up to 10% of the population. The more severe type of spina bifida have more characteristic skin changes. Occasionally, the unwary surgeon is persuaded to operate on these cutaneous changes, and we should advocate performing an MRI before any intervention, because he might lead to paralysis of this poor patient if he is not knowing that this is a spina bifida, which might affect the spinal cord of the patient. What is the myelomeningocele? It is the commonest severe type which is associated with neurological defect that may persist in spite of anatomical closure of the defect. But take care, up to 10% of the population may have spina bifida occulta. In this condition, the skin and tissue, but not the bone, may develop over the distal cord. The site may be identified by a birthmark or a hair patch. The incidence of this condition is reduced by use of folic acid supplement during pregnancy. That's why give your pregnant lady folic acid even before deciding to pregnancy. The prenatal counsel is important. The antenatal counseling is important. Give folic acid, prevent spina bifida occulta. The funny thing that one day I have encountered that a mother was very happy that her boy child has a hair in his back. But guess what? This is spina bifida occulta. This is might be a meningomyelocele. Please, please, lady, This is not a funny thing. Leave it alone and do MRI and consult a neurosurgeon. A very famous question in the exam will be about ankylosing spondylitis. So what is ankylosing spondylitis? Itis, it's inflammation. Itis, inflammation. It's a chronic inflammatory disorder affecting the axial skeleton. Ankylosing skeleton. So, chronic inflammatory disorder affecting the axial skeleton, this is the ankylosing spondylitis. And in the plain film, you will find sacroiliitis. In up to 20% of the patient, there is association with HALA B27 positive and will develop the condition of ankylosing spondylitis. But take care, the affected articulation develop bony or fibrous changes. And typical spinal feature will include loss of the lumbar lordosis and progressive kyphosis. Again, the typical spinal feature include loss of the lumbar lordosis and the progressive kyphosis of the cervicothoracic spine. So ankylosing spondylitis talking about the cervicothoracic spine, while when we are talking about the spondylolysis, we are talking about L4, L5 due to slippage of the vertebra with the spondylolysis. Again, ankylosing spondylitis, we are talking about lumbar lordosis and progressive kyphosis of the cervicothoracic spine and associated with HALA B27. So there is a strong association as well with the ulcerative colitis in such individuals. And the clinical findings are usually kyphosis affecting the cervical thoracic spine. Take care. Considerable symptomatic benefit may be obtained using the steroid anti-inflammatory drugs for those patients, for the ulcerative colitis and the ankylosing spondylitis both. And this should be carefully in patients with inflammatory bowel disease who may be taking steroids. Keep in mind. So take care. A patient with ulcerative colitis complaining of pain in the back. Take care. He might be ankylosing spondylitis. Keep this in mind. There is association. The association between the ulcerative colitis and the ankylosing spondylitis reminds me of the Gardner syndrome, which is a variant from the familial adenomatous bullopi, which is 100% cancerous. The FAB, the familial adenomatous bullosis coli, is 100% cancerous and associated with the Gardner syndrome with extraintestinal manifestation in the bone and congenital hypertrophy in the retinal pigmentation and mesenteric fibromatosis like desmoid tumor. So when you find desmoid tumor, think of Gardner syndrome. When you find a FAB, think of Gardner syndrome. Even if you find an osteoma of an mandible, which is even benign in 90%, think of Gardner syndrome. Exostosis, osteoma, dental abnormalities, think of Gardner syndrome, familial adenomatous bullopi, which is might be associated with retinal pigmentation, mesenteric fibromatosis, and desmoid tumor. All of those Gardner syndrome. Keep them in mind. In the exam, he won't ask you a direct question about the familial adenomatous bullopi and ask you for the association with Gardner syndrome. In the exam, he won't ask you about the desmoid tumor itself and ask you about it and its association. He will ask you with the description of the familial adenomatous bullopi symptoms and sign. He will ask you about the desmoid tumor symptoms and sign, and you have to make the association. So now you know it, you can link it and do the association. Just we like and link it the ulcerative colitis with the ankylosing spondylitis. So what is a desmoid tumor? Desmoid tumor are tumors that arise from cells called fibroblasts. They are presenting as lump-like from the skeletal muscle that most commonly develop in the anterior abdominal wall and shoulder girdle as well. Think of them and keep them in mind. And by the way, desmos is from the Greek word tendon-like, literally means tendon-like, and that's why it arises from the skeletal muscles from origin cell fibroblast. And when you decide desired to diagnose a desmoid tumor, think of it as a Gardner syndrome association. The desmoid tumor commonly to be from age from 15 to 40 in females more than male in the shoulder girdle or the upper arm and buttocks, trunk, head and neck, and even the abdomen is the most common site to be presented with, and the clinical presentation will be a painless or even painful mass, and when in close proximity to a joint, range of movement will be also limited, and the desmoid tumor must be in your mind with its association with Gardner syndrome. So now we are agreeing that desmoid tumor might be in the abdominal wall, in the limbs, or even breast or the buttocks or any connective tissue because it arises in the skeletal muscle wherever it present. Take care. And by the way, a history of trauma is often surgical to this site of the desmoid tumor is common in one in every four cases and even associated with implant. The implant itself didn't cause the desmoid and the trauma itself didn't cause the desmoid, but it's not known what caused this desmoid to happen, but it related us and made us take care that there is a swelling here. So the cause of the fibromatosis of the desmoid tumor is not known. It remains unclear. Some refer to the desmoid tumor to the trauma itself or hormonal factor like the estrogen, that's why it's more common found in the female, or even genetic association with trisomy 8 or deletion of 5q. Let's keep it with the Gardner syndrome for our exam, and even osteoma is the most forgettable thing in the exam, that the normal benign osteoma can be associated with the FAB, familial adenomatous polypi, and the Gardner syndrome. I know I took too much regarding the desmoid tumor, but hope you don't forget it by now until you find it in the exam. And remember that ankylosing spondylitis is associated with ulcerative colitis. And if it's a mass, how can you diagnose a desmoid tumor? Diagnose it with CT, MRI, and core needle biopsy. This is the trick. By your eyes, you can diagnose a desmoid tumor. You can guess of it from its common site. But to diagnose it, of course, it's a pathological diagnosis. It's a core needle biopsy.